right. Good evening, everyone. I'm Laurie Ledley, the founder and president of Valley Sleep Center. And tonight we are giving away a free watch pad. Thanks for joining. This is a home sleep test. This is all it is now. Isn't that so cool? So tonight with us, you must be present to win. So if you're out there on Facebook Live, we just want to say welcome, but next time register and you can be participating in our free giveaway. We have Missy Jensen, who is a nurse practitioner. She's going to be our presenter. She's the director of clinical engagement for Respicardia. She's going to be talking about heart disease and how untreated sleep apnea really perpetuates that. We're talking about central sleep apnea. She's going to teach us a little bit about obstructive sleep apnea. And then also we have Carrie with us, and Carrie, is it Rachel?
Rachel.
Yeah, Carrie Reichel is a clinical specialist with Remedy, and we're so thankful that both of you guys are here. If you guys have any questions while Missy is presenting, please put them in the Q&A down below at the bottom of your screen. If you're on Facebook Live, feel free to ask a question. But other than that, you can get started, and I'll draw the name of the winner of the watch pad. $300 value this is, guys. And I'll draw that name at the end of the presentation, right before the questions. So welcome, everybody.
Awesome. Thank you, Laurie. I am going to actually stop my video and share my screen. That way you can, you guys can focus on the slides. How's that? Did that work?
Yep, it's perfect.
All right, well, we will go ahead and dive in here. We're going to talk primarily tonight about the impact of sleep apnea on cardiovascular diseases and heart diseases. And we're going to kind of just dive right in here. A little bit of background on the types of sleep apnea, because it can impact how you're treated, and certain cardiovascular disease can make you at risk for both types of sleep apnea. And a lot of people really have no idea that there are two distinct types of sleep apnea. And the two primary types of sleep apnea are central sleep apnea and obstructive sleep apnea. Obstructive sleep apnea is the kind that you have most likely heard about. This is caused by a mechanical obstruction in typically the upper airway. Something in the tissues of your mouth or the upper airway cause a blockage of airflow when you're trying to breathe. Central sleep apnea, on the other hand, is very different, and it's a disease in which the signal from the brain to the breathing muscles is lost, and you actually have no effort to breathe. So here's a really good illustration of obstructive sleep apnea. You see on the left here really nice open passages of the airway where these purple arrows are really flowing nicely as you're trying to breathe when you're asleep at night. In obstructive sleep apnea, something in the upper airway, occasionally it can be actually in the nose, but it's most commonly in the soft palate or the tissues in the back of your throat and your tongue that cause a mechanical obstruction of the airway when you're trying to take a breath. And like I said, central sleep apnea is quite a bit different. It's a problem where the signal from your brain down through these big nerves called the phrenic nerves is lost. So there's no signal from your brain down to the breathing muscles, which is primarily the diaphragm. If you take a really big deep breath right now, you can feel your your chest expanding, and you can feel the diaphragm pulling down and lifting up as you breathe. And that signal is lost, so that during sleep, there's actually no effort to breathe. And that, again, can be treated very differently if we're trying to open an airway that's blocked versus trying to restore that signal. We're going to talk about the symptoms and how you know if you may need to be tested for sleep apnea later. But I wanted to bring it in here now because I feel like one of the biggest misconceptions with sleep apnea, or poor sleep in general, even if you just have a bad night's sleep once or twice a week, you kind of feel like you're tired and you're not functioning quite well the next day. But I think one of the biggest misconceptions is that's all that's involved, or that's all the downstream effects of having sleep apnea. And we know that actually that's not true. It has very significant and extensive long-term effects, and it causes both daytime and nighttime symptoms, which again, we'll talk about in detail later. But let's talk about those downstream long-term effects. Sleep apnea involves two problems. It involves the blockage or closing of your airway, or that lack of breath, which makes your oxygen drop. If you're not getting a deep breath, whether it's from central or obstructive sleep apnea, you have this drop in oxygen. And that causes the tissues in your body, your blood, and your heart to have low oxygen, which we call ischemia. Ischemia is a state of low oxygen in the tissues, and that leads to just a generalized inflammation. And then after you have that hypoxia, you have an arousal or a startle. And any of you guys have ever awakened from a dream, or awaken yourself snoring, you'll kind of know what I'm talking about. And it's the same arousal, exact same arousal mechanism as if you get scared. And that not only disturbs your sleep, but it also creates this surge of stress hormones, this surge of norepinephrine is the name of the hormone, that really is stressful. Not only makes you feel stressed, but over the long term, it's really stressful to the heart, and it causes a lot of, again, these downstream problems. So sleep apnea is really bad for you, both from the part where you don't breathe and have low oxygen, and then the arousal that causes this surge of stress hormones through the night. And I wanted to bring this in now because we're going to talk about the specific effects of sleep apnea on heart disease. And I think kind of having this background really helps you put all of this together. So over time, sleep apnea can cause depression. It can cause changes in mood. It can cause changes in how you're thinking during the day and memory. It can make you more at risk for diabetes because of that long-term inflammation of the tissues. It can make you more at risk for heart failure, which is a problem when your heart pump is not as efficient as it should be. We talked about memory and concentration. Many people with sleep apnea have a primary symptom of just really not feeling like they're thinking well, memory loss, not being able to remember tasks or kids' names during the day, in addition to feeling fatigued. It also could cause high blood pressure and other heart problems, which we're going to talk about in the next few slides. So who's at risk for sleep apnea? I like to start any talk about sleep apnea and cardiac disease with this slide, because as you'll see, the first four things on this slide are heart diseases or cardiovascular diseases. High blood pressure is a risk for sleep apnea. Atrial fibrillation, which is a very common abnormal heart rhythm. Other heart rhythms like ventricular arrhythmias, ventricular tachycardia, and premature ventricular contractions, which are very common, and even heart pauses are very much associated with sleep apnea. And as I mentioned before, heart failure, which is an issue with the pumping efficiency of your heart. So of the primary risk factors for sleep apnea, the top four are cardiac diseases. And the next three are risk factors for cardiac diseases. So what you'll see as we go through these slides tonight is that sleep apnea makes you at higher risk for heart disease. And also a lot of these heart diseases makes you higher risk for sleep apnea. And it kind of becomes the chicken or the egg thing. But what we know is if you have sleep apnea that is not treated, it makes it very, very difficult for us to treat your heart disease. So how common is sleep apnea in various types of cardiovascular disease? And here is, kind of a really, we'll have some slides on a few of these specifically to dive in here. High blood pressure, particularly if you require a lot of medicines, congestive heart failure, diabetes and stroke, which are actually cardiovascular diseases because they affect the vascular system, the arteries, the veins, the blood flow. And then common cardiac arrhythmias, which we'll talk about a few of those that are most common. So let's talk about high blood pressure first, because it is so common. And this again is very much a chicken or the egg, which comes first thing. And the answer is both. sleep apnea is an independent risk factor for high blood pressure, and having high blood pressure or hypertension is a risk factor for sleep apnea. So if you look at all the people with obstructive sleep apnea, which is the type of sleep apnea we have the most data on, depending on what paper or what research study you read, between 60 and 80% of people with obstructive sleep apnea have a history of high blood pressure. And if you have a diagnosis of high blood pressure, you're about 40% likely to also have sleep apnea. But if you look at people with what we call resistant hypertension, and that's defined in medical practice by having to be on 3 or more medications at significant doses or max doses to try to control your blood pressure. People with resistant hypertension are about 90% likely to have undiagnosed and untreated sleep apnea. And what we know is if we get that sleep apnea, no matter what type of sleep apnea, if we get that sleep apnea diagnosed and treated, is much easier to control your blood pressure. And you'll see that that's going to be a recurrent theme as we talk here tonight. So let's now talk about some different arrhythmias, abnormal heart rhythms, and we'll start with atrial fibrillation because I think it is the most common. If you look at various research studies and populations of patients, well over half of people who have had atrial fibrillation have sleep apnea. This is typically sleep apnea that is undiagnosed or untreated. Most of those will have obstructive sleep apnea. About 20% of them will have a predominant type of sleep apnea, that's that central sleep apnea. But what we know, and we've seen this in multiple research studies, really good research studies, is that having untreated sleep apnea increases your risk of developing atrial fibrillation over time, but it also makes it very hard to treat atrial fibrillation. So if you have atrial fibrillation, one of the first tests that you have as we're doing the workup, trying to figure out the cause and how to treat your atrial fibrillation, should definitely be a sleep study. I have had a brother and a brother-in-law and a nephew in the past 2 years who have been diagnosed with atrial fibrillation. And I will admit that I swooped in and made sure that each one of them had a sleep study to make sure that we were treating their sleep apnea. And also each one of them did have sleep apnea that needed to be treated. Because again, we know that treating sleep apnea improves the outcome of all types of treatment for atrial fibrillation. That means if you're on a medication for your atrial fibrillation, or if you have what we call an ablation procedure, where we do a specialized procedure in the cardiac catheterization lab to treat the atrial fibrillation and kind of stop that arrhythmia, much more likely to be successful, over 50% more likely to be successful if your sleep apnea is diagnosed and treated. This is a really interesting study out of Europe looking at patients who have atrial fibrillation and obstructive sleep apnea, who use their CPAP and who stop using their CPAP. So these are patients at the end of 1 year. In group A on your left, continued to use their CPAP. Group B were not using their CPAP at the end of 1 year. And what you see is in the blue here, 76% of patients in the CPAP group were still in a normal heart rhythm. And about a quarter, just over 23%, were actually back in atrial fibrillation. But look at the group who stopped using their CPAP. This is actually backwards, 65% were now back in, it is right, I'm sorry, 65% were back in atrial fibrillation, should probably be orange, and then about 35% were in a normal rhythm. So if you used your CPAP, 3/4 of them stayed in a normal rhythm. If you stopped your CPAP, you were much more likely to be back in atrial fibrillation. So what about other heart rhythms? Atrial fibrillation is one of the most common abnormal heart rhythms and one that a lot of you have probably heard of. But there are other heart rhythms, ventricular arrhythmias, where the pumping chambers of your heart have an abnormal rhythm. These are patients who may have an implantable defibrillator. to detect those rhythms and shock if needed. Patients with sleep apnea are much more likely to have ventricular arrhythmias. In fact, if you have heart failure, a decrease in the pumping ability of your heart, and you have sleep apnea, you're twice as likely to get shocked from an arrhythmia. So you're twice as likely to have one of these abnormal arrhythmias. And these arrhythmias are deadly without that shock and reshocking your heart back to a normal rhythm. These arrhythmias could be deadly. Patients with sleep apnea are twice as likely to have what we call in the cardiology world a sudden cardiac death, just where your heart stops in the middle of the night. Twice as likely if you have sleep apnea of any kind. And even what a lot of people just call slow heart rhythms, pauses in your heartbeat or heart blocks, are much more common in patients who have sleep apnea. So I want to spend a few slides talking about heart failure. Again, that pumping problem with your heart sounds horrible. It sounds like your heart is stopped, but what it means is your heart pump is just not as efficient as it should be. And heart failure is what I've spent most of my nurse practitioner career treating. Sleep apnea of every kind, in any kind, very common in patients with heart failure. And one of the reasons is because when the heart gets weak and the blood is not pumped effectively, what we call cardiac output, when your cardiac output drops, it can make you more at risk for having issues with both loss of signal, that central sleep apnea signal from your brain to your breathing muscles to breathe, as well as make it more likely to have obstructive sleep apnea. In fact, if you look at all of the heart failure patients in the United States, about 75%, so 3 out of every 4, will have some sort of sleep apnea that what we call clinically significant, meaning that makes you have symptoms. And the other, I think one of the biggest problems with having this treated and diagnosed is heart failure patients, and often their providers, tend to think about the symptoms as being part of the heart failure. Sleep apnea makes you feel really tired. Sleep apnea makes you get up a lot at night to go to the bathroom, or for any reason. Sleep apnea can affect how you think and your memory and your cognition, and so can heart failure. So it's kind of, these things overlap, and really you're trying to figure out which is heart failure, which is sleep apnea is hard. And in fact, you probably shouldn't do it if you have these symptoms and you have heart failure, really just getting tested for sleep apnea. Because kind of looking at these last 3 bullets, patients with sleep apnea and heart failure, they tend to have apneas that are, their bed partners, spouses or other bed partners can say, oh, you stop breathing in your sleep, or you gasp in your sleep, or you pant in your sleep. A lot of people who snore don't even realize they snore. And I think this is a very common argument, and I'm sure Laurie has heard this repeatedly, between bed partners and patients with sleep apnea as to whether or not they snore. If you have central sleep apnea, you very frequently don't snore at all. So snoring alone is not always a good marker for whether or not you need a sleep study. And again, people with sleep apnea, they're not aware they snore. They're not aware that they have these arousals, but very frequently their bed partners are. You jerk in your sleep, you stop breathing in your sleep, or you take really abrupt deep breaths. So a lot of the things other people appreciate, which makes it difficult if you sleep alone, because you can really not appreciate the nighttime effects of this. So still looking at heart failure, this is a big study from the National Institutes of Health that showed us 2 important things about patients with heart failure and sleep apnea, really of any kind. This is looking particularly at that central sleep apnea. What we know is that patients with sleep disordered breathing have more heart failure hospitalization, so more decompensation, getting really sick, filling up with fluid from your heart failure. And the more admissions or readmissions you have to the hospital, the more likely you are to have central sleep apnea. And then from that same study, looking at mortality or increased death rate compared to heart failure patients with no sleep apnea, having either kind of sleep apnea, if you look out here at 12 months, so 1 year, 2 year, and then 3 years after a heart failure admission, if you have sleep apnea that's not treated, you have twice the mortality, so twice the death rate compared with heart failure patients who have no sleep apnea. So kind of summarizing all that, we didn't specifically talk about stroke past that first slide, but sleep apnea that's untreated it reflects or is associated with twice the risk of stroke. Sleep apnea that's untreated is associated with two times the risk for sudden cardiac death, that when your heart just stops beating. 5 times the risk of overall cardiovascular mortality. We talk specifically about heart failure. And then a 57% increase. So I talked about this, over twice as likely to have recurrence of atrial fibrillation after you've had a treatment for atrial fibrillation. So again, I talked about it. I can't stress it enough. That a lot of times we associate sleep apnea with just being tired. But I hope I've kind of driven that point home tonight. A lot of, downstream effects, particularly on the cardiovascular system. So I'll finish up talking about how do you know if you have sleep apnea, or how should you get tested? And it's really primarily about how you're feeling, even in the daytime. Are you tired? Are you fatigued? Have you been told that you stop breathing at night? Do you really have trouble concentrating? Snoring is a great indicator, particularly of obstructive sleep apnea, but a lot of people do not snore. And a lot of people are not even aware that they snore. And then again, if you have heart failure or atrial fibrillation, you have such a high probability of having some sort of sleep apnea. Just having any of these things really would indicate that you should be tested for sleep apnea if you have not. So we'll talk about a couple of specific, but I wanted to dive into the symptoms, again, really stressing that you can have both daytime and nighttime symptoms of both obstructive and central sleep apnea. This slide particularly says obstructive, but this can apply to any type of sleep apnea. You're very sleepy or very tired during the day. And I feel very passionate. There's a difference between being sleepy and tired. Some people feel they're sleepy. They could doze off at any moment. They could doze off while driving. They can doze off while reading or having a conversation or sitting in church or watching television. But some people don't really doze off. They just feel exhausted or tired all the time. In fact, in our pivotal trial for the Remedy device, the #1 subjective complaint of patients was just feeling tired. Again, memory and concentration dysfunction, forgetting things. We've had patients who can't remember their kids' names, who can't remember errands. Actually, having gastroesophageal reflux, particularly in the early mornings, can be a sign of sleep apnea. Any kind of behavioral change, irritability, depression, fatigue, again, the memory loss, sleep apnea or fatigue from poor sleep is the most common cause of traffic accidents after alcohol. And then at night, we already talked about a lot of these symptoms. Not everybody snores. Not everybody is aware they snore. But I really want to point out here just the waking up to go to the bathroom. I used to have patients tell me that they don't go to the bathroom very much in the daytime, but they go several times during the night. And we think this could be associated with those arousals that I mentioned. You have that apnea where you stop breathing, your oxygen saturation, your oxygen percentage gets really low. And then you have that arousal where you have that startle that makes you then wake up and feel like you need to go to the bathroom. So just be aware that you could have symptoms both in the daytime and the nighttime of sleep apnea. So how do you take a risk assessment? There are a couple of different things you could do. This is one in particular that's called the STOP BANG, and it's called the STOP BANG because it's an acronym. So the S is for snoring, the T is for tired, O is for observed apneas or observed, has someone observed you stopping breathing. P is for blood pressure, high blood pressure. B is for body mass index, and that's the comparison of your weight to your height, age, neck size, and gender. I put the website for the Stop Bang website. The folks who did the research on this are out of Canada, and this is one of the most commonly used tests to test for both symptoms and risk factors for sleep apnea. So I'll pause on this for just a minute if you want to write it down. And then I'll show you how easy it is. If you go to this website, it will actually bring up the Stop Bang questionnaire. So you can say, yes, I snore. I'm tired all the time. We'll say, no, no one's ever told me. I do have high blood pressure. If you're not sure of your body mass index, so if your normal weight, the body mass index is typically 25 or less. So make sure you check inches and pounds here. And so let's just say 5'10", 175 pounds. It'll actually calculate your BMI for you. And then you can go back in here and check yes or no, or over 50. If you don't know your neck size, a lot of folks don't now, you could probably just select no here. If you really feel like measured around the center of your neck, your Adam's apple, that your shirt size would be more than 16 inches, you can click yes. I feel like if you don't know and you click everything else that applies to you, it's going to give you an answer. So anything higher than 3 or higher is intermediate risk. 5 or higher is high risk. So it could give you an indication. And then also I wanted to call out Valley Sleep Center's website. When you first log into valleysleepcenter.com, and Lori can put this in the chat, I'm sure, you'll get this ask a sleep coach, and you could put in your information and they will kind of get a screening assessment out to you, which is very helpful, I think. So if we go back here, again, that's a website that will take you to that Stop Bang questionnaire. And then I'm going to finish up here, and I really want to allow time for questions, but I think this is one last set of powerful numbers. If you look at the entire adult population, about 1 in 4 or 25% has some sort of sleep apnea that's clinically significant. And what that means, it causes a negative impact on their life. But if you look at patients with heart disease or cardiovascular disease, that's 60%. That's not quite 3 out of 4, but getting close. In patients with atrial fibrillation or heart failure, it's more like 3 out of 4. And I think the number to the right is the most powerful one for me. Most patients, by far, 85% of patients with sleep apnea are not diagnosed, have not been tested. And the only way to really get diagnosed is to have either a home or an in-lab sleep apnea test or sleep study. And then treatment can be based on the type of sleep apnea that you have. And I will say, no matter what kind of sleep apnea you have, obstructive or central, there's so many treatment options now. There are so many different types of PAP, CPAP, or pressure masks, some that aren't exactly masks at all, some that are very minimal. And there are, for both types of sleep apnea now, non-mask options that really can treat your disease. So if wearing a CPAP is what keeps you from getting a study, I will say don't let that be the thing to keep you from getting a sleep study. And let's get you studied. And then there's so many other options for treatment out there now. So get tested and get treated. And Laurie, that's my last slide if we want to take some questions.
All right, so before we start the questions, I just want to show everyone how easy it is to get tested. So at Valley Sleep Center, you can actually have a virtual consult with a sleep physician. You can get a watch pat, which I'm going to give one away, mailed to you. This is how easy it is. So you wear this little guy on your chest, and then this goes on your finger, and you wear it like a watch, and that's why it's called Watch Pat 1. So really, really easy to get tested now. And again, lots of options. You know, it's not just CPAP, there's oral appliances. And, you know, if you have central sleep apnea, obviously Remedy. There's also Inspire if you have severe sleep apnea and you can't wear CPAP. So there's lots of options. And I myself struggle with obstructive sleep apnea. I'm severe and I had the Inspire implant. So that Ask a Sleep Coach box that Missy popped up, that comes directly to me. So if we don't answer your question tonight, right now, please reach out to me on my email or that Ask a Sleep Coach. So let's go ahead and stop the recording. Thank you, everyone.